Okay, I want to welcome our guest today, Dr. Benjamin Johnson of Fairleigh Dickinson University, who was a student of mine long ago, and now he's an
Mhm.
assistant professor of psychology. So, why don't you tell everyone a little bit about yourself and sort of what you do at Fairleigh Dickinson and a little bit about your background?
Sure. So I'm an assistant professor, as you mentioned there. It's my second year now at Fairleigh. Um, I have a range of things that I do on a daily basis. So I'd say my time is split relatively evenly between teaching doctoral students in clinical psych, supervising doctoral students in their outpatient psychotherapy work, um, and then doing a good amount of research myself, and then mentoring research, so PhD students in their dissertation work and independent research. So that kind of takes up most of my time. I originally graduated from Penn State, and my main area of interest is personality disorders, primarily borderline personality disorder. So I have a background in a number of different treatment approaches to BPD, and really, I'm very invested in both research and kind of applied benefits of research for people with the disorder and their families. So,
Yeah. So, borderline personality disorder and personality disorders in general are probably one of the more complicated
right.
sections in the psychological disorders class. So, first of all, what sort of got you interested in borderline personality disorder? It's a fascinating condition in general, but what sort of initially got you thinking about it?
Yeah, I didn't know much about it. I didn't know anything about it at all in undergrad. And actually, my maybe junior year of undergrad, um, read or I think I watched the movie version of Girl Interrupted, which I know Ken. Um, but that got me interested in kind of the disorder in kind of a pop psych way. And then just by happenstance, I ended up working as a research coordinator for 2 years after I graduated, at a clinic at Emory where they had an adolescent and young adult dialectical behavior therapy program. And my job there was to assess, basically the emotion dysregulation and behavioral patterns of teenagers who were in this program. And so I was seeing these kids, 14, 15, 16 year olds who were coming out of the hospital after, their third suicide attempt. And they were really kind of severely struggling in many ways in their life. And they would join this clinic and start DBT and we get substantially better in relatively short period of time, 6 months, a year. And I was so struck by both how in distress these kids were, but how much better they seemed to get over the course of this treatment that we were had them in. And it just captivated me. I just wanted to know more about the disorder and know more about the treatments for the disorder. And so when I applied to grad school, I applied, um, and the second time I applied to grad school was primarily solely PD programs, both from a dialectical behavior therapy standpoint, but also a psychodynamic standpoint. And then in my graduate training, got exposed to psychodynamic understandings of PDs and BPD. And so now I like to, think and work integratively in trying to understand personality disorders. But that's kind of where I started.
Wow. I mean,
Yeah.
and you're right. It is a very fascinating condition. And how would and you can the DSM sort of explanation of borderline personality disorder is its own thing, but
Mhm.
now that you know the condition and you're generating research and different understandings about the condition, how would you explain to someone what borderline personality disorder is?
It's a really good question because, at least in the field of PDs, there's a lot of pushback on some of the limitations of the DSM understanding of PDs and BPD. It's funny because I have two parts of my brain that try to answer that question. One is the kind of cognitive behavioral side, that thinks about kind of the DBT explanation of BPD. And I when I talk developmentally about personality disorders, I use kind of Marshall Linehan's biosocial theory, which in gist basically suggests that BPD is really difficulty regulating yourself that happens when you are, a kid who is kind of born into the world with high levels of emotional sensitivity. We everyone kind of ranges along a continuum of how sensitive we are, and some people are just more emotionally reactive. You put those people in an environment that isn't really conducive to supporting them or teaching them how to regulate their emotions or learning about emotions, or if they experience a lot of invalidation or bullying or lack of support, you end up with, an adult who struggles to regulate their emotions, or who has self-harm, or who has, thoughts of suicide. And so that's kind of the behavioral model of BPD, independent of the DSM criteria. I often think about just kind of mood dysregulation and a history of invalidation. The psychodynamic understanding that I use is can be a little bit complicated and abstract, but in just, I think of BPD, and when I teach my students about it from a psychodynamic perspective, I just talk about how BPD is really a disorder of identity and a difficulty knowing who you are over time and who other people are to you. And so people with BPD often have these kind of rapid shifts in their understanding of themselves. One day I might feel good about myself, the next day I might feel terrible about myself. And part of the work in a dynamic treatment for BPD is to help people have a more consistent, complex view of themselves, seeing I have both good and bad parts. I have strengths and weaknesses, and those don't have to be at odds. I can figure out a way to exist in a more complex gray way. And my relationships can also be the same, as opposed to, you know, one day my relationship feels amazing, the next day it feels terrible, and then we break up and I start over. Right. So um I could also talk about, kind of more modern empirical understandings of personality disorders if you want. But that's kind of how I think about it more clinically, because I tend to think pretty clinically about
Yeah.
PDs.
And what do you feel like is one of the most, like, misunderstood, like, what do people misunderstand about BPD?
I'd say a number of things. One is that it's not treatable. That's a common misunderstanding. PDs and BPD are difficult to treat. I mean, as you pointed out, they're complex. They are distressing very much for the person who has it, but also people around them, and also for therapists working with people who have BPD. But if you are at the very least familiar with what personality disorders are and have any kind of training in how to deal with a lot of emotions in the room, and how to be both validating but firm, and have boundaries to your therapy, then BPD and other PDs are very treatable. They actually have good prognoses for severe disorders. Mary Zanarini, who's a researcher I really respect, talks about BPD as the best prognosis major diagnosis that one could have. It has a better prognosis than schizophrenia or bipolar or these other disorders that have significant um, you know, distress and dysfunction associated with them. So it's very treatable. Um, I think another common misconception is that people with BPD are manipulative or unlikable. And having worked with many, many, many people with BPD or other PDs, um, it's 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 very much a misunderstanding of somebody who's been misunderstood for most of their life in many ways. And often what you actually learn about, working with someone with BPD is that the way in which they're coping is the best that they know. And so if my emotions are very intense and I don't know what to do about it, I might reach out for help in ways that other people don't understand or other people aren't used to, right? I might turn to, cutting myself because I don't have any other better way to, turn off negative feelings. And so it works, right? It works for people, but is misunderstood, I think, from the outside. So that's definitely something that when I, supervise or talk about PDs, try to change that kind of stigma that's associated with the disorders.
And it's probably true of people who are clinicians, as well as as people who are learning about the condition, in terms of some of those sort of stereotypes around it.
Definitely. A lot of I work with training, either junior or even senior clinicians on working with PDs. And if someone hasn't gotten a framework or an understanding of what a PD is or how to work with it, it can be very overwhelming, to see somebody who has BPD. But just a little bit of education and kind of a model or a manual or a treatment approach goes a long way, I think, with working with someone with a personality disorder. It can be really helpful.
Probably with most psychological disorders that you're treating, there are gonna be sort of strong emotions that you'll need to sort of gird yourself against. All
Hmm.
right,
Hmm.
whether or not it's depression or anxiety or strong emotions. As a psychologist, you're always often on the other side of that.
Hmm.
So what
Hmm.
do but it's especially the case with borderline personality disorder. So what
Right.
are some things that you do to help you in those situations where you're at the receiving end of some of those strong emotions?
Yeah, no, it's a really good question. Across the board, regardless of how you're working with someone with BPD, All of the advice that I've been given and that the treatment manuals are built on is that you have to work in a team or with either supervisors or colleagues who you can turn to for support. And I think that's essential when you're working with strong emotions, regardless of if it's BPD or otherwise. Um, you have to have kind of a support system working on your own without anyone to turn to when you feel overwhelmed by a patient who has maybe a significant trauma history and is coming in very distressed and is maybe also angry. You have to have somebody to turn to after that session to be like, I just need to decompress or I need to touch base about this case. I think that's essential. Um, and in my case and in many people's cases, and this comes in part out of my psychodynamic training, there's I think a lot of openness to having your own therapy, going to see your own counselor or someone who can kind of support you in having good mental health and well-being to stay kind of grounded when you're seeing somebody who doesn't have that yet, I think is really crucial. And that has been helpful for me in the past as well as I was a trainee, learning how to treat PDs.
Yeah. I also believe that understanding psychological disorders does not necessarily help you only if you're going to go into the field. I think it
Hmm.
helps you to understand people in general and how to get around in the world.
Hmm.
So in what ways, if someone understands more, has empathy for people with BPD, how is that going to help them if they're not going to go into the field of psychology? How might it help them in their everyday lives?
I mean, I've heard this many times, and I like to quote is everyone has a personality, right? Everyone you interact with, regardless of what your career choice is, your family, my family members have a lot of personality, right? Like everyone has a personality. And so understanding so the more kind of modern ways of thinking about personality disorders have moved away from this idea that you either have it or you don't. And instead, most of the data suggests that everyone kind of exists along this bell curve of how much of certain personality traits we might have, right? One person might be more extroverted, someone else might be more introverted. And I think if you're exposed just to understanding how personality works and how personality guides how we relate to other people or we relate to ourselves and our own self esteem, it's such a useful construct to hold on to, regardless of where you go in life, because you can understand, oh, these personality traits that I have, lead me to interact with people in this way, or lead other people to interact with me in this way. I tend to be more extroverted, and the people I'm around are more introverted. Knowing that that might cause some tension is really important. It's no different in a way than working with somebody who has a personality disorder. Is understanding what's going on in our interaction and our relationship becomes a central focus of the therapy. That I think that focus of looking at how are we relating right now, and is it working or is it not, I use that all the time, regardless of where I am. If I'm, trying to get on a flight and I have to like deal with the person at the gate because, they're making me pay $250 for a bag. This happened on my honeymoon recently. So I'm thinking about it. Knowing that, oh, this person's doing their best, but we have different goals right now and we're having a little bit of a rupture, but that can be worked through. It just comes from working with, personality disorders and being a clinician in
Yeah, I
general.
think you're absolutely right. I think, you know, knowing those tools can
Hmm.
be really helpful in lots of situations, but also how to help regulate your own emotions,
Exactly.
which depending upon the situation, can be extreme or may need to be more extreme than they are.
Yeah, I mean, you do have to, I think, become good at noticing your own emotions when you're working with BPD, because a lot of emotion can be evoked in these sessions, and that is a useful skill, in general, to be able to just be self aware of what am I feeling right now in any given moment.
Mhm.
I mean, so if you practice DBT, you learn and have to practice yourself being more mindful, right? Being more aware of your own emotional states, and I think that's just so useful in so many respects.
Yeah. I want to switch a little bit and talk about your research because you're
Sure.
sort of creating new knowledge and understanding about different conditions. Is there research that you've done or that you are currently involved in that you're really excited about that you want to share with people?
Yeah, the current study my lab and I are really trying to get underway. We're about to start collecting data actually in the next couple of weeks. I'm really excited about is it's a multi-site study, so we're running it both at Fairleigh Dickinson and at Penn State, which is where I was before. And we're recruiting undergraduate students who have had recent thoughts or behaviors of self harm or suicide. So not necessarily particularly BPD, but we're looking at the kinds of symptoms that people experience who have BPD. We're interested in suicide and self-harm and trying to help, alleviate those behaviors. And we're recruiting these participants to actually, over the course of 12 weeks, complete a number of very quick surveys on their phone. And what we're trying to do is to use some more advanced statistical tools to be able to predict for a given individual, for just, you, Ken, or me, Ben, what days am I most likely, after what types of experiences, to experience a thought of suicide, right? So for me, maybe class stress is really, it really gets me going, right? And so on Friday nights, I'm least likely to experience suicidal thoughts, but on Monday mornings, I'm very, likely to experience these thoughts of suicide. Knowing that for a given individual can be super helpful, because then we can actually, the next phase of this study, we're going to try to implement some mobile interventions, some mobile tools where people can be pinged on their phone. Today might be a hard day for you. Try breathing more, using some of these mindfulness skills, et cetera. So we can actually tailor the interventions we use to specific people in specific moments, rather than what often we're left, only the only kind of recourse we have is somebody comes into a therapy session. We try to help them for an hour, and then they go back out into their life and have to kind of manage things on their own. So we're trying to use some more, more personalized tools to predict for each individual in our study. How can we help them better in the moment? So I'm really excited about that study, which we should start collecting data probably in this month.
That's great.
Yeah,
Well, thank you for answering the questions about this.
sure.
Excited about what you're doing and excited to see what might be coming up. So
Yeah,
thanks
me
so
too.
much.
Thank you. It's
Yeah.
been great.